Good evening, all the aspirants present here. Today's session is Obstetric Emergency CBS session, and the speaker that we have here today is Dr. Neeraj Kumar, sir. He is an Associate Professor, Anesthesiology and Critical Care at AIMS Patna. Thank you, sir. So you may continue.
Okay, very good evening to all of you and all EDIC preparators. I hope that today's class is related to obstetric emergencies, and what I have planned it that I will try to discuss few important aspects of obstetric emergencies, and then followed by I have kept few of the questions. This is type A and type K questions is already there, but this is all only for your practice, so that you cannot miss any of the stems if it will be available in your exam. Say if you follow a preeclampsia stem, if you get a clinical question on preeclampsia, so they can ask various aspects of preeclampsia, then the patient will land up in eclampsia, followed by they may be developing some features of HELP as well in preeclampsia, HELP following, and then following your eclampsia, and then later on what is the definitive management for eclampsia, and then maybe few of the questions if the patient will, after that the patient underwent some obstetric complications like postpartum hemorrhage, so how will you going to manage that patient? So it will be like that. But here what I have tried to cover all important aspects that has been equally asked in the previous EDIC examination in EDIC part 2 as well. So I will be covering important aspects like physiology of pregnancy, few points, and then postpartum hemorrhage, then some points related to severe preeclampsia as well, then HELP syndrome, amniotic fluid embolism, then your peripartum cardiomyopathy, then following your cardiac failure in pregnancy, how it happens, and what are the basic physiology that is associated with these cardiac failure patients, and then few points about that board regimen, what is this board regimen is all about. There are lots of things that we will discuss later on when I will be starting my discussion. Meanwhile, if you'll have any questions related to any of the point, or if you'll feel any doubt in between that class, you can definitely write in the chat box for any queries. And if the query will be unsolved, then we will try to answer on latter day, or I will pass all those answers to the first academy, and then they will give you all those information, because only to save that time it has been done from my side only. And I think now it's time to start that why these obstetric emergencies are really very important for all of us, or for your EDIC examination point of view. So till now, we all are aware that this pregnancy and postpartum, these postpartum women, they requires ICU admissions, and they constitutes only 0.1%. Means you can say that less than 0.1% of all pregnancies required. That pregnancies are related to ICU admissions, and of all those less than 1% of ICU admissions, their patient will have some obstetric problems. But the problem is that they are mostly admitted for obstetric conditions rather than any other unrelated medical complications. So their primary mode of admission inside that ICU, we'll discuss that what could be the various obstetric causes for ICU admission and non-obstetric causes for ICU admission as well. And most of these patients, many of time, these patients are belonging in a postpartum phase of the period, for which they require ICU admissions, with exceptions of trauma and cardiomyopathy, because it can affect at any parts of the pregnancy status, like your intrapartum, postpartum, or peripartum period. Any it could be anything. And then trauma, definitely trauma-induced coagulopathy is another important aspects that may happen in many of the pregnant patients as well. Now, there has been few studies that they found that the SOFA score is a better predicting system for basically for obstetric patients, for predicting mortality in the obstetric patients. But when you will read about further details about this SOFA, I think for obstetric patient, for emergency emergency triaging, now another term is that is your emergency, or there is a modified SOFA or modified obstetric SOFA. So for which you have to read that part also. They may be asked in your exam that what is modified obstetric SOFA as well. But right now, still we are using, or the various schools of thoughts, they still say about SOFA for predicting mortality, even in the special groups of patient like your obstetric patients, like not only in obstetric, means specifically in obstetric groups of patients. I think still SOFA is one of the important cause for predicting the mortality as well. Okay. And now the important thing is that actual mortality rates are dependent on the disorder that has caused that patient for a ICU admission. Now, the important thing is this is the thing that I was talking, that there was a very good study which was published
Yes.
in the Hong Kong journal, and so I request all participants just please mute. Okay, so it was a very interesting study that was published in your one of the ICU of Pamela Neither Seoul Eastern Hospital, basically from that Hong Kong. It was published in Hong Kong Medicine Journal, and they basically analyzed that clinical characteristics and outcome of the obstetric patients, those who are admitted in the intensive care unit. Although the sample size was very low in this for obstetric patients, those requiring a ICU patient, it was only limited to 50, but you see that total number of ICU patient in this year from 1998 to 2007, around 7,692 ICU admissions were there, out of which 50 patients were exclusively admitted for the ICU, obstetric ICU patient, constituting less than 1% of the total ICU admissions for obstetric patients. And then if you'll see the total number of delivery that institute has been taken care of, out of which 50 patients have underwent ICU admission. So again, it is less than 1% of the approximately 1% of the less than 1% of the ICU requiring all delivery as well, requiring that ICU admissions. Now, among these diagnoses, out of these 50 patients, those who are admitted to the ICU, so 35 patients were admitted because of the obstetric cause, and rest 15 patients were added because of the non-obstetric cause. But if you'll see that in obstetric cause, the few of the findings, like if you leave this PPH, apart from PPH, there are other like pregnancy-induced hypertension, which constitutes eclampsia, severe preeclampsia, and HELP syndrome, then amniotic fluid embolism, then your ruptured ectopic pregnancy, and your peripartum cardiomyopathy. So all these constitute, even the APH also constitute around less than 2% of that percentage of the total patients that were admitted. So these all are your questions for your EDIC examination. Why? Because if you'll see about postpartum hemorrhage, then PIH, amniotic fluid embolism, ruptured ectopic pregnancy, not much, but they can ask definitely about that massive transfusion protocol and policies, and then your peripartum cardiomyopathy as well. And then few of the points related to maternal sepsis or obstetric sepsis as well. But now here, if you'll see that obstetric causes, now interesting to see non-obstetric causes as well. So non-obstetric causes, sepsis, which was the leading cause for admission, and out of which UTI was most common, following your respiratory infections, and then few of the cardiac related admissions as well, in which your rheumatic heart disease was one of the cause. Then CNS related admissions were also there, like viral encephalitis, intracranial hemorrhage, as well as meningitis, and then thrombocytopenia and postoperative monitoring. Although these constitute a bit lesser one, and but obstetric and non-obstetric causes has to be understand in terms of the examination as well, and these are the important topics that we have to read. Okay, now coming to the next part, that now what the physiological adaptations is there for any patients who are pregnant. So there are many physiological changes, and it occurs at the level of fetus as well as placenta. So these are the changes that occurs at the level of fetus, placenta, and at the level of the mother. So modification occurs in almost every organ system has been modified in these groups of patients who are going to get pregnant, right? So many of these patients, the important role is hemodynamic monitoring and ventilation, the two important factors or two important systems that we have to understand. Why? Because we know that progesterone is very important hormone that is responsible for providing these adaptations, and it is one of the most potent smooth muscle relaxant and respiratory stimulant as well. So these are additional two properties of progesterone. It has a smooth muscle relaxant effect, as well as it can increase the respiratory center for providing more respiratory stimulant functions. And then after delivery, what happens that it takes about 6 weeks, means at least 42 weeks, 42 days is minimum for maternal physiology to return to that normal level. So again, this may be asked in your examination, that what is the minimum duration at which the physiological adaptation is going to return to the normal pre-pregnant state. Okay. Now, here again, if you'll further read about that maternal pregnancy adaptations, most dramatic physiological adaptations are cardiovascular, and this is for us because in the exam this cardiovascular system adaptation is going to get, they are usually going to ask these questions with various questions related to cardiovascular physiology as well. Here the first one, the blood volume increases progressively at least up to 50% of in the singleton pregnancy. And then why? Because to compensate the blood loss which is going to happen during the delivery, and the placental vasculature, it is constitute around 30% of the cardiac output. So it constitutes around 600 ml per minute at term. So if it has been asked that what is the amount of blood that has to be present in the placenta at the time of term, so it should be 600 ml per minute. And then around 16% of this maternal blood volume is located in the uterus. So again, this is important aspect, that only 1/6, like 16% of the maternal blood is going to localize in the uterus. And the blood pressure again going to decline by the first trimester, declines during the first trimester to the nadir value, and typically the value ranges from 85 to 110 to 50 to 70 in the second trimester. And these blood pressure again returns to the pre-pregnancy values in the latter part of the third trimester. So you may be going to see some of the shifting in the blood pressure when it is related to your first trimester, second or third trimester. Now, again, important is if you'll further expand the expansion in the maternal blood volume, and the support of placental blood flow is again important. Why? Because to provide adequate fetal growth. So first, cardiac output increases by 40 to 50% by the 10 weeks. So by 10 week, it is the accountability of around 50%. And why? Because there is a sudden increase in the stroke volume, as well as the heart rate is not going to increase too much, because there is only a slight increase in the heart rate, but the stroke volume too much increasing, the increase in the values of the stroke volume is noticed, and that's why the cardiac output increases by 50%. And there is marked reduction in your total peripheral resistance. So that's why the patients will have a systemic vasodilatation, and that's why the blood pressure, diastolic blood pressure, falls more than systolic blood pressure, especially in pregnancy patients, if you see about the physiological adaptations. But what I told you, that in the third trimester of pregnancy or in the later part of the third trimester of pregnancy, these patients will be attaining their blood pressure to the pre-pregnant values. And aortic caval compressions, we all know that it compromises the preload and it increases the afterload in this patient. That's why supine hypertension syndrome is one of the finding, although it's a very rare finding, but it may be very drastic, and it may be a catastrophic complications if aortocaval compressions is not going to get managed. And if for this point of time, you have to optimize that afterload, and you have to increase that preload as well for managing this supine hypertension syndrome. I will go a bit fast also, so that I can cover more parts. And then what happens many other times, that because of significant hypotension, the placenta will be the solely vital organs that is separated from the maternal mother vital organs. That's why they experience a severe vasoconstriction, and it is the basically a reflex mechanism is there in the placenta when it is connected to the fetus. Because if some problem will be there in the maternal vital organs, like hypoperfusion will be there, so immediately placental vasoconstriction will be there, will be result in the fetal hypoxia, as well as the patient will land up in the decrease in fetal heart rate, or there will be noticed in decreased variability in the fetal heart rate, or maybe few of the times the patient will be having a bradycardia. So first sign of the maternal decline is your decrease in the variability of the fetal heart rate. Again, this is a question that they can ask in the examination. What is the first sign of the maternal status decline when the patient will have a fetal distress? They will not give fetal distress as an option. They may ask the decrease in the fetal heart rate variability. And then if the mother will lose up to 30% of the blood volume before her vital signs changes. So at least 30% of the blood volume has to be compromised for getting a severe changes in the vital signs. Now, again, important part related to cardiovascular, I have discussed. Now, hematological, we all know that in hematological, the plasma volume is always more. The plasma volume is always more. And then why? Because there is increase in the red cell volume, and then dilutional reduction in hemoglobin concentration. Patient will have a neutrophilic reactions, like neutrophilia will be there. These patients might be having a mild thrombocytopenia. That's why many of these patients, if they develop preeclampsia, they can have a problem for developing HELP syndrome as well. And then hypocoagulable state, these patients have a hypercoagulable state. In the respiratory system, if you see, the patient will have increased respiratory rate, increase in tidal volume and oxygen consumption as also, and the patient will have increase in minute ventilation. So all will increase except your residual volume as well as functional residual capacity. So this is going to decrease. And pregnant women normally have what they have. If you do ABG, the patient will have a slightly respiratory alkalosis with a compensating metabolic acidosis. So these patients will wash out the CO2 more because they want to maintain that, because the minute ventilation is very high. That's why the patient will have that respiratory alkalosis features. And the important thing is that how they will compensate with metabolic acidosis, because why? Because the fetal CO2, there should be increased removal of fetal CO2 and acidic metabolites, leading to that compensation leading to that compensation about your metabolic acidosis. There may be some diaphragmatic mobilities that decrease diaphragmatic mobility is being noticed in the latter part of the pregnancy as well. Now, in the renal, yes, the GFR is going to increase. That urea, the creatinine concentration will fall. There will be mild reduction in the sodium level as well, and the net gain fluid balance will increase in this patient, because the patient will have a more mineralocorticoid effect, because of which the more fluid retention will be there. That's why the patient will get weight gain will be also there. And then here in GIT, the patient will have a constipation or some GERD, leading to more risk for aspiration prophylaxis is needed more in these groups of patient if they are pregnant, because of the compromised lower esophageal sphincter. And then patient will have increased alkaline phosphatase and decrease SGPT as well as albumin level. Now here one fact is there: if the maternal oxygen partial pressure of oxygen, if it is going to get below 47 millimeter of mercury, the umbilical vein concentration begin to decline. So you can think that umbilical vein concentration will umbilical venous oxygen concentration will decline only when your maternal oxygen concentration falling below 47 millimeter of mercury. So if it can sustain, so 60 it will not decline, 50 it will not decline, so it will be around 45 to 47. So then only umbilical venous concentration will going to get declined. Now, again, a important thing is that vasopressor of choice. Now, again, this is one of the frequently asked questions in the case-based scenario exam many of the times, because these pregnant patient, if they have to be delivered via elective cesarean sections or any emergency cesarean sections, the spinal anesthesia is very commonly used procedure for delivering those babies. That's why maternal hypotension is very frequently encountered in these groups of patients. And because of the vasoconstriction occurs in almost all of the vessels during the pregnancy, it is also important to use a agent or use of drugs which preserves the uterine blood flow and prevents that intrauterine growth retardation, prevent the fetal compromise as well. And then these uterine vessels are at a time they are maximally dilated. So they are maximally dilated only because they have a predominant alpha receptors, and they play an important role in determining the sensitivity to any drugs which is having a property of sympathomimetics. So any sympathomimetic agents, because these uterine vessels are very, very dilated, so you have to take care of that things also. Now, how? So first you will see there are 4 different aspects, like drugs like yours ephedrine, phenylephrine, dopamine, and your vasopressin. Okay, so these are a few drugs that has been used for preventing that, preserving that uterine functions or uterine perfusion. Now you see one by one that what is the problem with each of the drugs and which is the choice that has to be used in these groups of patients. So first is your ephedrine. Definitely is a preferred drug, but problem is that they have in spite of having it, they have a good safety records, but and third also important point, that they have a minimal effect on the placenta at low doses as well, but it crosses the placenta. You have to remember in your mind that ephedrine is going to cross the placenta, and it has reported that the patient will have a fetal tachycardia as well. And many of the fetuses has developed acidosis, especially in compromise. If the fetus is already compromised, the acidosis and fetal tachycardia will be more if you are using ephedrine. So 3 points: preferred, good safety records, as well as minimal effect on placenta, low doses. But problem is they crosses the placenta, and they have to be used. If you're planning to use, you have to use in a bolus doses for short-lived hypotensive episodes. So if a short-lived hypotensive episodes are there, only preferable is to give bolus. No confusion about starting that about starting a continuous infusion dose. It is not there. It is with phenylephrine, but not with ephedrine. Now coming to the phenylephrine, it's not written that it is preferred. It has not written that it has a good safety record, but definitely it causes more uteroplacental vasoconstriction. But problem is there is no fetal acidosis. It is bit more safe for neonates, and it has a lesser adverse effects or lesser adverse outcomes in comparison with ephedrine, and it has to be given for infusion as an infusion agent. If you think that that hypotension has lasted for quite long time and your longer duration of hypotension is there, for these groups of patients you can use phenylephrine. Now coming to the dopamine again, it has studied in the patient with having underlying septicemia, and then overall effect on the uterine blood flow is still not elucidated. Here it can cause acidosis or placental fetal tachycardia or acidosis, or it has not been documented. Although only point is there that it is a better choice of inotropes, especially because it does not increase the pulse rate. It does not consistently increase because it consistently increase the pulse rate but does not increase the MAP. So if you doesn't want to increase that MAP, and if you doesn't want to increase the MAP, you can give dobutamine as a choice of the drug in few of the selected groups of patients. Now coming to the vasopressins, again no point for safety records, no point for the preferred agent, only intravenous and intramuscular administration of vasopressin because it can cause a uterine contractions, and it has been frequently used in for providing a uterine contractions. Now for a few words about noradrenaline and epinephrine. So again, they are considerable vasoconstriction. They poses a very important vasoconstriction effects at the maternal and placental vasculature, especially in hypoxic women. And here for epinephrine, short-term use of epinephrine for anaphylaxis does not decrease the fetal blood flow. So in meanwhile, if the female patient underwent some anaphylaxis, definitely you can start with epinephrine. Like subcutaneous adrenaline can be used, and they have suggested that no fetal compromised blood flow is there. So this is a nutshell about various aspects that if they will going to ask what are the sympathomimetics that you will use in as a vasopressors of the choice in patients for prevention of maternal hypotension. So these are the few points, and then their justifications. Now, important point that we'll again switch back to most obstetric hemorrhages occur in the fetus. When the fetus is going to deliver, the obstetric hemorrhage has been encountered. And these postpartum hemorrhages then complicate 5% of the delivery, which I have already discussed initially. And then drug therapy with oxytocin, definitely after delivery is one of the standard of care that has been very frequently used by obstetricians as well inside your OR. And then additional oxytocin they used to give in an infusion dose if bleeding is still continuing. Okay. Now coming to the another part, there are a few other drugs like third line therapies or second line therapies. Second line therapy, carboprost, methylergonovin, and then misoprostol is considered as the first and the second line therapy. First line definitely oxytocin, and then methylergonovin, and then misoprostol. Methylergonovin has a special property that it is a ergot alkaloid that is metabolized by a cytochrome P453A4, and it is primarily acts on the uterine smooth muscle. So it is one of the important property, but the problem is it can cause a severe hypertension when you want to give a IV bolus. It can cause a severe hypertension, and it can precipitate the myocardial ischemia, especially if the patient is having a cardiac problem, underlying cardiac disease, and if you are going to give a methyloglobin for stopping that bleeding, it will be problematic for that patient. And then a standard of care, you can start with oral therapy, which for at least 24 to 48 hours after the initial intramuscular dose. So if you have started an intramuscular dose, definitely after 24 to 48 hours, you can switch off to methylelgovin to oral therapy as well, like you're switching or sandwiching therapy. Now, again, important point is postpartum hemorrhage. So till now, you must be aware about the definition of postpartum hemorrhage, that it is an obstetric emergency. It can follow vaginal or a cesarean delivery. It is one of the important cause of maternal morbidity as per a Cochrane database. And then commonest cause of ICU admission, which as per Hong Kong Medicine Journal, which I discussed initially in my initial presentation. And then PPS definition. So these are the older definition that if you encounter a GI bleeding of GI tract bleeding after delivery of of more than equal to 500 ml after vaginal birth or more than 1 liter after cesarean, then you can define its pph. But this definition is no longer continued, but still a subjective definition is there, so that a quantitative estimation of the values is there. If the patient going to get delivered, baby is going to get delivered by cesarean, what would be the cutoff value? And if by vaginal birth, what is the cutoff value for defining your pph? But important is the definition is this one, that is very, very effective and very, very important, because it has 2 or 3 different aspects. Like excessive bleeding makes the patient symptomatic and it results in the sites of hypovolemia, just like what we used to follow in hemorrhagic shock. There are 4 stages of hemorrhagic shock, class 1, 2, 3, 4, in which ATLS we used to read that how based on the estimated blood volume, the blood loss is there. If more than 40% of the estimated blood volume is there, so you can think of the patient is going class 4 hemorrhagic shock as well. But here, if the blood loss is 10 to 15%, 10 to 15% blood loss, blood pressure will be normal. The patient will start complaining of lightheadedness and tachycardia. If the patient will have a 35 to 45% of the blood loss, so blood pressure will go below around 70 millimeter of mercury, the patient will have a air hunger, anuria, and collapse. So this is the, I think this is the 2 phases where you have to act. Otherwise, the patient will land up in this stage, and it is very difficult to save those groups of patients. That's why if the patient will have a tachycardia, sweating, or lightheadedness, you have to start managing that patient, and you have to identify that the pph has occurred, and now this is creating a signs and symptoms to that obstetric groups of patients. Now coming to the primary pph, secondary pph, again this is one of the commonest definition that they used to ask. If pph agreeing, maybe in the long question or in the case based, they will give the patient will develop the secondary pph, and after development of secondary pph, these are the complications that has happened. So if they have asked about secondary pph, so you must understood that the pph has developed it has developed after 24 hours and up to 12 weeks of delivery, so at least 84 days, so at least 3 months. If the patient is delivering, if the patient is having a blood loss for at least 3 months, maximum cut of 3 months, minimum cut of 24, then you can label it as a secondary pph. And then you have to think of some of the causes why this patient is having a secondary pph. That's why it is also known as late pph, and this is early pph. So this is more catastrophic, this is more stable. Now coming to the next part, 4 T's. We all know that 4 T's. This question may be asked in your clinical case scenario, that the patient will CCS, like your flow and loops. They can ask 4 T's or 4 loops of pph. So this is very frequently asked question, 4 loops of pph. So you have to write tone, trauma, tissue, and thrombin. So underlying coagulopathy, retained placenta, and any trauma to the traumatic cervix, traumatic vagina, and perineum, and anus and rectum, and uterine atony, which is again one of the most common cause of pph. Now coming to the next part is initial, how you are going to manage that initial. Again, this is a question that which can be asked as a STEM exam, as a STEM form, because they can ask that how will you manage that initial pph if the patient has developed. So must remember that you have to tell the answer that has to be started by, sir, I will take a large bore IV access. Otherwise, if you tell anything, they will not ask, they will not give you that total marks. Why? Because they will understand that this guy is missing an important aspect. Until unless you will take IV access, you are not going to give any crystalloid, any blood products, anything as well. So you have to start that I will take even you will say IV access, it is not a complete answer. Large bore 16 gauge IV access is more proper answer for managing these class 3 or class 4 hemorrhagic shocks. And then 3 ml. Now this is again this is because I have taken this from a John Hopkins Manual of Gynecology and Obstetrics. I think now fluid resuscitation estimation as per this as per John Hopkins Manual, they say that 3 ml crystalloid per ml estimated blood loss has to be given, and you have to consider consider 1 to 2 liter of blood loss, you have to think of starting giving PRBCs and then supplemental oxygen, FFP 15 ml per kg body weights. So 1 unit for each 4. If you are transfused 4 units of PRBC, so you have to give 1 unit of FFP. And why? Because it reduces the dilution and cytotoxic coagulopathy as well. And if the platelet, only if your platelet count is going below 50 lakhs. Now, another point is if the patient, all these agents fail, so uterine tamponade strategies has to be followed. Arterial ligation, embolization, uterine compression sutures, or at last resort, hysterectomy has to be planned for those groups of patients. Blood products should be infused needed during surgical treatment as well. So there is a role of recombinant 7A, but it has a potential role. Often when you are planning to do a surgical intervention in your patient, then it has to be given. Otherwise, its role is futile because after the failure of other drug management, it can be used. But although it's still the various school of thought, but it has been found that if you are planning for surgical intervention and you give a recombinant activated factor, so it decreases the mortality in few groups of the patients as well. Now, coming to the treatment for specific cause of PPH. So if the patient will develop a uterine atony, so you'll give a bimanual massage. You can give methylargonin and prostaglandins as well as oxytocin. If the laceration is there, surgical repair, vaginal packing. If the patient will have a retained product of conception, definitely you will give a ultrasound guided curettage. And then if the patient will have a coagulopathy, so FFP, cryo and platelet transfusion. Here, I think the role of TEG is there, or ROTEM is there, where you can identify that whether the ongoing coagulopathy is there or whether the patient is having a fibrinolysis. So coagulopathy and fibrinolysis based on seeing that R values, K value, alpha values as well, and then lysis as 30%, or for by seeing that clot strength and maximum amplitude, you can think of adding either FFP, tranexamic acid, or cryoprecipitate, or prothrombin concentrates like that, or platelets, apheretic platelets, or your SDP. Now coming to the few facts, I think only fact is there that FG2 alpha and PGE1 analog. What are the facts? Like prostaglandin, carboprost, and mesoprost. So these are most commonly used in hypertensive patients. Why? Because they can cause a significant contraction of the smooth muscles. Problem is that they may be associated with diarrhea, and carboprost often required a loperamide therapy. So this is carboprost that has a problem of producing more diarrhea. So loperamide therapy is required. Misoprostol is inexpensive. Best study while using rectal, oral, or sublingual administration. Vaginal route is not recommended for these PGF2 alpha, recommended because bleeding may dilute or estimate, because you will be not able to estimate the exact volume loss that has happened in these groups. But if it has to be used, 800 microgram or 1000 microgram is the dose. And now coming to the next part, uterine artery embolization, in which you can see that how these femoral artery has been cannulated, and after these angiographic catheter has been utilized, it is going to the embolize the uterine artery as well, and then it will prevent the bleeding. So it is only used for the patient if they are stable. If they are stable enough to transfer, then only you can plan for uterine artery embolization. Many of the time this question has been asked, just like CECT in traumatic patients. If the patient will have abdominal blunt trauma abdomen, if the patient is stable, then you will go for CECT abdomen. If the patient is not stable, you can directly shift this patient to the OR. Definitely, similarly, like in obstetric emergencies also, if you are not able to manage PPH by all those medical treatments, by all those drug and blood products, then you can definitely think of uterine artery embolization, but only in cases where the patient is stable. Few of the patient we have saved the life by reducing the bleeding as well, in our experience. And now coming to the surgical therapy, only name has to be remembered, like exploratory laparotomy, B-Lynch technique, compressive sutures, O'Leary technique, because in O'Leary technique, they used to bilaterally ligate the uterine artery, and then the ligation of the anterior division of the intrailiac artery as well. And then final term is hysterectomy. So if these not work, so hysterectomy is the last resort. Now coming to the next part. So this is how the B-Lynch technique has been applied. Here the suture is passing over the uterine surface, and then now the same level, the upper uterine entry point, the suture has been applied, and then entire, you can see the posterior bite of the suture has been taken, and then suture passing over the posterior uterine surface as well. And these are the marking in centimeters. That it's not very important, but definitely B-Lynch suture they may ask in your exam. Now about Novo 7, that is recombinant factor 7A. So approved indication when the patient is having a hemophilia A or B, exhibiting inhibitors. If the patient will have a deficient factor 8 or 9 or some congenital A7 deficiency, definitely you can think of adding recombinant factor 7A. Off-label use for hemostasis in obstetric and gynecological hemorrhages as well. And they also recommended one of the study which was published in hemostasis way, which they found that bolus dose of 60 to 90 microgram per kg body weight is to be given repeated injection within 30 minutes, and if there is no clinical improvement. So this is one of the role. And now this is one of the question, I think this is one of the question like related to women trial. Again, it's a very famous trial in which maternal antifibrinolytic therapy was given for postpartum hemorrhages. So these are the options. I will not go in details because these are the things that already been discussed in EDIC part 1. But yes, you have to read about the women's trial as well. That what is this all about? This is a study protocol that was published by Shakur, and it is already there in that database. So you can see that it's a very large trial, and it has, I think it has done in good number of patients, like 15,000 patients were there, and it was an international randomized double-blind placebo-controlled trial. Okay, so you all can go and at least have a look about this trial. And now PRH, that is pigment-related hypertension. So it is again second most common hypertension diagnosis. Now this again is important, that chronic hypertension, preeclampsia, in the exam they are going to get asked. So define, how will you define preeclampsia, severe preeclampsia, like that. So preeclampsia, if the patient will have elevated blood pressure with proteinuria, always only after 20 weeks of gestation, and the patient is must be normally normotensive earlier. Mild preeclampsia, I'll not go in detail. Severe preeclampsia, it used to ask in the exam. So severe preeclampsia, blood pressure at bed rest 160, systolic 110, diastolic, proteinuria greater than 5,000 milligram for 24-hour collection, or you get 3 plus protein or urine analysis, which is accompanied by oliguria, cerebral or visual disturbances if the patient will present, if the patient will have a epigastric or lower right upper quadrant pain, if the patient will have a right upper quadrant pain with impaired liver function, with some visual disturbances or oliguria. Maybe they will not give a visual disturbances, but they will give a oliguria and right upper quadrant pain. So it will be very difficult to think that whether it's a severe preeclampsia. So, and then evidence of MAHA as well, like microangioparetic hemolytic anemia. Now here, so similarly, based on that HELP syndrome, which we all know, that thrombocytopenia less than 1 lakh. So LDH will, how will you know that the patient is having a hemolysis? By checking for the LDH level, by checking for the microangiopathic hemolytic anemia, and then by checking for the increased bilirubin as well. And AST/ALT is also going to increase, which is equal to 70 units per liter. Eclampsia, generally defined as preeclampsia, accompanied by, if the patient will have a if the patient will start developing convulsions, or if the patient will have an unexplained coma. So these patients will have a eclampsia, and this patient may develop in without any hypertension, the eclampsia will develop, and without any proteinuria, the patient will develop. Okay, so these two important rule out that the patient is not having a preeclampsia. Here, the patient will have a right upper quadrant pain, again mimicking with preeclampsia. The patient will present with vomiting as well. HELP syndrome can occur in postpartum period, and it has a more risk for developing of pulmonary edema. Okay. Now here the facts, just I will summarize one. Pathophysiology is highly variable, but it is thought that because of the failure of trophoblastic invasion of the spiral artery, which is which is most important pathophysiology for the development. And here the fetal growth restriction occur in preeclampsia secondary to the hypoperfusion and hypoxemia of the placenta. So it is always hypoperfusion, or which is always secondary hypoperfusion, which is responsible for the development of FUGR or IUGR. Preeclampsia is more common in always more common in primary gravida, and it is more common when the patient will be having a first delivery or first pregnancy. Now, the second fact is the preeclampsia is rare. So it is rare before it is happening 20 weeks of pregnancy, but definitely many of the times they can give a scenario like 18 or 20 weeks of gestation. The patient will develop right upper quadrant pain. The patient will have a massive proteinuria. So you can think that there may be some form of preeclampsia that they're going to ask. But always you think, remember that if it is prognosis is very, very poor, if these groups of patients presented less than 20 weeks of gestation. So this is one of the important point that has to be remembered, that if it is occurring before 20 weeks, the prognosis will be always very, very poor. And this is the diagnosis that what I have already discussed, that cutoff is 140/60, and then your diastole is more than 90. But for severe preeclampsia, that what I have discussed, this is very commonly asked, that for severe 160, 180, and it has to be at blood pressure during bed rest. Okay. Now, proteinuria is not required to diagnose preeclampsia. So many of the times we think of that the patient is having a protein, but it is not very much. It is not always required. But yes, you have to remember that 5 gram and 3 plus protein has to be positive. Okay, now coming to the next part. This is Mississippi classification. Again, very frequently asked classification for diagnosing thrombocytopenia. HELP syndrome, class 1, very severe. 50,000 platelet count, AST, LT more than 70, and LDH more than 600. Here, this is between 50,000 to 1 lakh, and this is between 1 lakh to 1.5 lakhs. So rest all findings will be normal. So means all will equal to 1. Okay, equal to class 1. So this is Mississippi classification for HELP syndrome. Now, severe preeclampsia, I already discussed that mortality is very high, and the maternal mortality associated HELPs is like renal failure, DIC, hepatic damage. And then many of these HELP patients present antepartum period around 70% of the patient, and remaining 31 of the patient can occur in the postpartum period. So postpartum period, always try to deliver these patients within 48 hours. So this mother's safety is priority. Yes, 34 weeks of gestation, delivery is the optimal treatment. Cesarean is in every case. Close monitoring, and many of these women, some shows a spontaneous resolution within first 48 hours without any surgical interventions. HELP syndrome, yes, role of antenatal steroid, dexamethasone 10 milligram IV over be used for fetal lung maturity. Okay, I'm audible, huh?
Yes, sir.
Okay, for fetal lung maturity, and then aggressive anti-hypertensive therapy, then termination of pregnancy can we think of if the pregnancy is less than 24 weeks. Seizure prophylaxis can be added, and close monitoring of the vital signs, which I already discussed. HELP syndrome, yes. Few words about when you'll tell that this patient is having a postpartum HELP syndrome, which is occurring primarily in the first 2 days, but it has to be described late 7 days after childbirth. And if the platelet transfusion may be necessary in the woman, if the platelet count is going below 20,000, although the cutoff is 50,000, but if the patient will start oozing after surgery, so it is important to give platelets before going it for surgery. Now, again, the facts for HELP syndrome is eclampsia can occur without symptoms of preeclampsia. First point. Term preeclampsia is used to describe grand mal seizures occurred during the pregnancy, which do not have another identified cause. So that the seizure is grand mal seizure. And the third point is HELP syndrome is generally considered a variant of preeclampsia. Fourth point is both condition can occur in the later stage of pregnancy, leading to HELP syndrome. Which is hemolysis, elevated liver enzyme, and low platelets. And then HELP syndrome can occur without proteinuria or hypertension, but majority of the patient have preeclamptic symptoms. Okay, and HELP syndrome is a severe form of disease, which is approximately occurring in 20% of the severe preeclampsia. HELP syndrome may require delivery of the fetus. Okay. So this is one of the question related to the this is related to the HELP syndrome, but I will go directly to the not to the question, but directly I will go to the it's fact that for parenteral magnesium sulfate therapy, the important is the magnesium sulfate regimen include a loading dose of 6 gram IV over 20 minutes, followed by continuous infusion of 2 grams per hour, starting during a period of observation and continuing until 24 hours postpartum. So this is one of the point. So, and the second point is, if the seizure is not controlled by 2 such boluses of magnesium sulfate, then only you can think of adding any other anti-epileptics like diazepam, lorazepam, and midazolam. And ACOG task force have recommended that magnesium sulfate therapy in the setting of preeclampsia is useful for preventing the recurrent seizures. Now here, for antihypertensive treatment, ACOG task force recommend that for severe eclampsia and HELP syndrome, blood pressure of 160 by 110 is very, very important, and antihypertensive therapy has to be started. And this is 3 facts that you have to remember, that when to add anti-epileptic after how much doses of your magnesium. Now, this is again another question, but again, I will go with the facts here. I have already discussed there are 3 classes of HELP syndrome. For class 1, severe thrombocytopenia, and moreover, the actively bleeding patient, if the platelet count going below 20,000, patient has to receive that platelet transfusion. But here, important is repeated platelet. If you want to transfuse, repeated platelet transfusion are not required. Why? Because of the short half-life of the platelets. And now important is that if you want to add corticosteroid therapy to the platelet transfusion to increase the platelet count? No, it doesn't improve that maternal outcome in the HELP syndrome, and it is recognized as normalization of the platelet count and health of the hospital stay, but it does not increase the platelet count. That's why here I have just kept one option, that addition of platelet transfusion to increases the platelet count and improve the maternal outcome. No, so it doesn't increase or improve the platelet count, and it neither improve the maternal outcome as well. Now coming to the next part, seizure prophylaxis. Yes, loading dose 6 gram, then 2 gram per hour is the IV dose, and therapeutic concentration of magnesium is 4 to 6 milliequivalent per liter. Antihypertensive therapy, definitely IV hydrolysine is the choice, IV labetalol. If the alternative therapy doesn't work, then you have to give. So this is an interesting slide, I think, in which you have to understood that MP ratio, that is how this maternal and placental ratio, like milk and milk as well as your milk to plasma ratio of a few of the drugs. So here I just want to highlight here this part, that your all ARBs like candesartan, irbesartan, and valsartan, they have a very they have a very high protein binding. They have a very high protein binding and unlikely unknown lipid solubility, and they have probably no human case has been reported that they enters into the milk, but MP ratio, that milk is to plasma ratio, is unknown. That's why low molecularity of these drugs agents suggest excretion into the breast milks. That's why if the mother is going to take that ARB for treatment of hypertension, many other times it is going to excrete, because there is still the milk is to plasma ratio is still not defined in this group of patient. Rest every patient has his own milk is to plasma ratio. But just for your understanding that ARBs doesn't have, that's why no human reports is available, and their recommendation is not there. Okay. Now the second is important thing is your carvedilol and labetalol. Again, if you'll see that carvedilol with comparison with labetalol, so this labetalol have a moderate protein bindings, and this lipid solubility is also low, and they enters the breast milk, and their milk is to plasma ratios between 0.2 to 2.6, and labetalol is compatible. No reports has still been presented. Okay. Now, fluid management. Fluid management is only you have to look for the risk for pulmonary edema, that it should not be happen, and there should be no over resuscitation has to be there. So this is one of the important question: hepatic capsular rupture that has happened in severe preeclampsia, and severe preeclampsia. All these questions already I have discussed. Severe preeclampsia, I have discussed all those classifications, that when you will define what is the platelet visual loss, and then your creatinine insufficiency, pulmonary edema, and then your antihypertensive 160, 110 is the cutoff. Platelet will be less than 1 lakh, like that. Now, second point is amniotic fluid embolism. So I will go quickly because time is less. And the rare complications, high morbidity and mortality, and clinical features. You all know that these patients will have a labor and delivery or immediately at postpartum. The classical symptoms: hypoxia, hypotension, and shock with altered mental status. But here I would like to highlight the diagnosis of exclusion, and this is on the DD is this can be asked in the exam, that pulmonary embolism, then your hemorrhage, then your anaphylaxis, and myocardial infarction. So these are a few of the DDs of amniotic fluid embolism. So this is how it works. The patient will have a amniotic fluid exposure of fetal antigen. So there may be few of the cause like complement activation, coagulation activation, mechanical obstruction, consumption coagulopathy, and then release of various biochemical mediators. So these are all pathophysiology for the development of acute fluid embolism or amniotic fluid embolism. Many of the time the examiner used to ask that, can you enumerate few of the mechanism of action of amniotic fluid embolism? So at that point of time, you have to tell that, sir, there are some immunological release of a few biochemical mediators like leukotrienes, like your interleukin 1, TNF alpha, and thromboxane A2. So these can cause your all of these can cause activation of your complement activation, and then overall your acute pulmonary hypertension, hypoxia, or right ventricular failure. Okay. Management, yes. Early diagnosis, first priority is to deliver the fetus, aggressive supportive management, good IV access, volume support, packed blood cells, and FFP. You can use prostaglandin synthesis inhibitors or high-dose corticosteroids, but it only because if the patient will have a inflammatory cascade, to combat that inflammatory cascade, this has to be given high dose of corticosteroids. Okay. So this is again of the question, diagnosis. This is again another question, but here I will discuss that what are the two classes. The two classes is typical AFE and atypical AFE. So typical AFE is been characterized. Typical AFE has been characterized by here the phase one. The patient will have a phase one respiratory problems. Okay, so the patient will have phase one respiratory problems, phase two coagulation disorder, and phase three is acute renal failure. Atypical, in contrast to embolism, the patient will have a cardiopulmonary collapse, and then the patient will have a life-threatening hemorrhage due to DIC. Okay. So these are the few of the presentations. And then peripartum cardiomyopathy, again, this is a diagnosis exclusion, usually occurs in the last month of pregnancy. Important is that the patient will have a classic development of cardiac failure in the last month of pregnancy, no identifiable cause of cardiac failure. Additional, the patient will have if you do a strict echocardiographic examination for checking for left ventricular dysfunction, what you'll find, you'll see three different findings, like EF will be less than 45%, the fractional shorting of the at M mode will be there, so it should be less than 30% as well. And in diastolic dimension, again, it is the in diastolic dimension, the diastolic dimension will increase, so it will be more than 2.7 centimeter square centimeter per length. So it should be like that. And if it is falling, yes, meeting the diagnostic criteria, so you have to involve three team at one go, like cardiologist, obstetrician, and perinatologist. So this is the risk factors like advanced maternal age, multiparity, obesity as well. Now, peripartum cardiomyopathy, a few of the etiologies like viral myocarditis and autoimmune diseases. But here I want to highlight, yes, you all know that significant right heart failure will be there, jugular venous distension and paroxysmal nocturnal dyspnea. But I want to highlight this point. Prognosis is dependent upon the normalization of the left ventricular functions. So when the left ventricular functions will normalize, the prognosis will be improved. Second important is the role of your, yes, the important is the predictors for the poor prognosis of PPCM. What are the predictors? So if the EF is already very less, so less than 25, poor prognosis. If the in-diastolic dimension is more than 5.5 centimeter, and if you are doing a QRS and every QRS time you are seeing that shortening less than 1.120 milliseconds, again the problem is poor. And if the mother is subsequently been pregnant, then again the problem is big problem will be more. ACE contraindicated, ACE inhibitors are contraindicated, hydralazine and nitrate should be used, dopamine, dobutamine, nitroglycerin or milrinone is required in management of acute. But here I want to highlight that IVIG, like IVIG, pentoxifylline and prolactin inhibitor has been successfully tried for the management of PPCM at a dose of 1 gram. Okay, and next point is that how these prolactin inhibitors are important, because you see that here, if you want to give a IVIG, it is mostly reserved for the treatment of infective origin of your peripartum cardiomyopathy. So if the TNF alpha can be given in a patient in the left ventricular dysfunction, pentoxifylline inhibits the TNF production, and pentoxifylline 400 milligram TDS can be given, and left ventricular diameter was significantly smaller, and there were fewer deaths in pentoxifylline group. Okay. Prolactin derivatives definitely have a role, like oxidative, because it combated the oxidative stress, and prolactin derivative because it halts the endothelial cell apoptosis and disrupts the capillary structure. That's why prolactin inhibitors are very safe, because it has been found that prolactins may be one of the problem for that apoptosis and disruption of that the capillary structures. So this is board regimen. Board regimen is being used for your peripartum cardiomyopathy managed. B stands for bromocriptine. O for oral heart failure drugs like beta blockers and ACE inhibitors. A stands for anticoagulants, heparin. R used for vasodilators like relaxants, and D used for diuretics. So they may be asked in the exam that what is board and what is the full form of board regimen as well. So this is the same question that is based on that theory that what we have discussed, like board regimen is used for acute PPCM, M mode fraction shortening, like this is the dimension. So I have already discussed all those things. Now, this is important aspect that cardiac failure in pregnancy, few important thing that you have to understand the concept of a stroke volume and then your left ventricular in diastolic volume. So in the x-axis, left ventricular in diastolic volume, and in the y-axis, stroke volume is there. And this is the curve. So what will happen here on increasing, if you want to fill the left ventricle, if we want to fill the left ventricle, it leads to progressive increase in the stroke volume, definitely. Okay, feeling, it will increase the stroke volume, and it will reach a point. It will reach a point X, after which, if you want to overstretch, overfill, it will not increase the stroke volume, and the volume will start to fall. Okay, so here at this point of time, the stroke volume is optimized, and now the volume start to increase. And here, what will happen? So here now you see one diagram. Okay, so here right side shows a cardiac failure, and the left side shows improved myocardial contractility on increasing. Initially, if you'll try to increase, fill the ventricles, fill the stroke volume will increase, and which with cardiac failure, what will happen? With cardiac failure, the shift of this curve will be towards the right. And why? Because the muscle is now very, very less reactive or less effective. The muscle is now not more working. That's why here the inotropes has been added. So the concept of adding inotropes is here. So here you want to add a inotropes. Okay. So inotropes, why? To improve the muscle contractility. And then this is the basis of starting your cardiac therapeutics or cardiac drugs, that why to add and when to add. So if you'll see, if your stroke volume is increasing, and after that, if not increasing, so you have to fetch that time that when it has to be added, when that inotropes has to be added. And we know that intrathoracic pressure increases, it will compromise the venous return. Venous return means left ventricular diastolic volume, and then it means preload. Okay. So cardiac failure, preload, diuretics, afterload, vasodilators, intermittent positive pressure ventilation, and PEEP, good sedation. You want to decrease both preload and afterload as well. Few points about acute fatty liver of pregnancy. Yes, fatty acid oxidation defect is the problem. Mortality rate is 18%. Ammonia can be produced by the hepatic cells. It can present at late at 23 weeks. Definitely in acute fatty liver of pregnancy, what happens that the patient will have a jaundice, diabetes insipidus, decreased level of antithrombin 3, and then the patient will develop hypertension or preeclampsia, and there is no report of AFLP resolving prior to delivery. Okay. Now, these are the lab diagnosis. Hypoglycemia is important because you have to remember the Swenson criteria for diagnosing acute fatty liver of pregnancy. And here, what you want to do? It worsen during the first 2 to 7 days after. Mostly postpartum, it develops, and followed by the improvement in the hepatic, renal, hematological, and pancreatic function will be there. If liver transplant is indicated, if liver rupture with necrosis has happened, fulminant hepatic failure has happened, hepatic encephalopathy, if the advanced stage hepatic encephalopathy is there, then you can think of liver transplantation. Activated protein C has been used to treat basically sepsis underlying AFLP. There is role of plasma exchange as well. Now, what studies they have done, that receiving plasmapheresis in progressive acute fatty liver pregnancy, with a deteriorating mental status, persistent coagulopathy, and renal failure, they found that all of these issues were resolved within 14 days after completing the 3 cycles of plasmapheresis. So this is a differential diagnosis: AFLP, severe preeclampsia, HELP, viral hepatitis, TTP. So ICP is intrahepatic cholecystitis pregnancy. Again, it is very important again for the examination point of view, because it is characterized by pruritus. Here, pruritus will be patient present, elevated bile acids will be there, transaminitis will be there. Maternal prognosis is generally good if the generally good with disease progression, and it is limited by the delivery. and the patient will have a fetal morbidity and mortality as well. And there may be association with some postpartum hemorrhages in severe cases. That's why. Why? Because of the absorption of fat soluble vitamin like EDIC. Then potential causes of jaundice. Again, this is a same question, that what will be the potential cause of jaundice in critically ill obstetric patients. So you start with AFLP, you go with obstetric cholestasis, hepatitis, definitely viral hepatitis, then septicemia, then some primary biliary cirrhosis, sclerosing cholangitis. So this is AFLP question. Again, this is Swenson criteria I've asked here. This is the Swenson criteria, like clinical features: nausea, vomiting, abdominal pain, polyuria. Laboratory features: important is leukocytosis, hypoglycemia, more ammonia level 47, and then coagulopathy AKI. So these are the few lab features. Ultrasonographic finding ascites, and histopathology microvascular steatosis in the liver biopsy. So this is all about from my side, and I think I have covered most of the important aspects because the time was less. And but you all guys go and read all these important aspects, because obstetric emergency now a very emerging topic for EDIC 2 examination, and this is only a sensitization for you all, because every day the reading is required. The materials are there, but definitely you brush it 2, 3, 4 times for marking all those questions accurately. Okay. So if any questions are there, I will be happy to answer. Anyone have any doubt? Because in our case based, when we'll take exam, I think this will be, the question will be like this only. You will be getting a case related to severe preeclampsia. The patient will have all those findings of severe preeclampsia. Then step by step, I will ask all this question, that how will you define severe preeclampsia? What are the diagnostic modalities? How will you going to manage this patient? Now, suddenly this patient have thrown a seizure. So for seizure, what prophylaxis that will good? What is the dose of magnesium? When you will think of magnesium toxicity in your patient? And then whether you want to add some steroids, whether the steroids have any role in managing that seizures, what are the choice of antiepileptics that you will use, how will you control that hypertension, what are the drugs that you avoid for management of that hypertension. So there are n number of questions, and definitely at the end, if you all guys will answer well, then I will take you to acute fatty liver pregnancy, where liver transplantation is required. Then I will enter into the liver transplantation. What are the orthotopic liver transplantation indication, and what will happen when the transplant failure will be there. And then in between, I can ask what is the role of your therapeutic plasma exchange, and what is the role of your DAMPS, that is your DAPS, DAPS. What is the role of DAPS when it is combined with TTP? So these are few advanced questions then when you will be exactly appearing for your exam. So till now, I think you all guys go and read. It's a very interesting, obstetric is very interesting, but yes, frequent practice is required. Okay. So if you don't have any question, I will be happy to leave and enjoy your weekend and keep continuing, keep studying.